anesthetic consideration in liver failure, sir. So the liver is the largest organ in the body and receives 20 to 30% of cardiac output. It has dual blood supply via hepatic artery and portal vein. Liver has widespread physiological roles, including metabolism of carbohydrates, proteins, and lipids, synthesis of albumin, immunoglobulin, clotting factors, glucose homeostasis, bilirubin formation and excretion, drug and hormone metabolism. Patients with liver disease who require surgery are at greater risk for surgical and anesthesia-related complications. Magnitude of risk depends on types of liver disease and severity, surgical procedure, and type of anesthesia. The term liver failure comprises large spectrum of pathological process that lead to the impairment of the synthetic and metabolic function of the liver. First is acute or fulminant liver failure. It is a new onset liver failure including jaundice, coagulopathy, and encephalopathy in a patient without pre-existing cirrhosis. It is defined by O-grade classification, where the time from jaundice to hepatic encephalopathy within less than 7 days is hyperacute, within less than 4 weeks is acute, and within 12 weeks it is subacute. Coming to chronic liver disease, it is a progressive deterioration of hepatic function over a period longer than 28 weeks. It is a continuous process of inflammation, destruction, and regeneration of liver parenchyma typically occurs. Subsequently, fibrosis and distortion of the hepatic architecture occurs, leading to cirrhosis. The chronic liver disease can be either decompensated or compensated. In compensated, the patient is asymptomatic. Sometimes it is often undiagnosed. In decompensated, the patient will have jaundice, ascites, hepatic encephalopathy, and varicose hemorrhage. Next one is acute and chronic liver failure. It is a syndrome of rapid onset deterioration in hepatic and extrahepatic organ function on a background of chronic liver disease. It is characterized by severe systemic inflammation, extrahepatic organ failure, and a high 28-day mortality. History in liver disease. We should ask for history of alcohol consumption, prior blood transfusion, history of multiple sexual partners and sexually transmitted diseases, illicit drug usage and tattooing, family history of liver disease, and any current medications or over-the-counter product prescriptions. Coming to clinical features, the patient might have general malaise, fatigue, anorexia, weight loss, feeling of enlarged abdomen, swollen abdomen or legs, nose bleeding or bleeding from lower limbs, jaundice, itching, hand tremors, palmar erythema, splenomegaly, gynecomastia, and testicular atrophy in men. The systemic manifestation of chronic liver disease includes in CNS, the patient will have a hepatic encephalopathy, which is a potentially reversible neuropsychiatric abnormality thought to result from the reduced metabolism of neurotoxins such as ammonia, short chain fatty acids, and mercaptans. In CVS, the patient will have hyperdynamic circulation with a high cardiac output and low systemic vascular resistance. The patient will have a relative hypovolemia. Secondary to systemic and splanchnic vasodilatation, the patient might have cirrhotic cardiomyopathy due to diastolic dysfunction, prolonged QT interval, and blunted contractile response to stress. Coming to RS, there will be a mechanical compression of lung from large volume ascites and hepatomegaly, which can lead to impaired lung movement, alveolar hypoventilation, decreased functional residual capacity, and atelectasis. The patient might have hepatic hydrothorax and then hepatopulmonary syndrome, which will present as dyspnea and hypoxemia in the setting of chronic liver disease caused by intrapulmonary arteriovenous shunting. And then the patient might have portopulmonary hypertension due to an increase in intrapulmonary vasoconstriction and marked vascular remodeling in patients with portal hypertension in the absence of other causes of arterious or venous hypertension. Coming to GI, the patient might have portal hypertension secondary to an increased pressure gradient between portal veins and hepatic veins, manifesting as varices, splenomegaly, and ascites. The patient might also have spontaneous bacterial peritonitis. Coming to renal, the patient might have acute or chronic renal dysfunction. The patient might present with hepatorenal syndrome, which is the end result of progressive impairment of renal perfusion secondary to worsening hepatic failure. And then nutrition, the patient might be malnourished, muscle wasting can be seen, hypoglycemia, hypoalbuminemia, and impaired wound healing would be present in the CLD patients. And in endocrine, the patient might have adrenal insufficiency, secondary hyperaldosteronism leading to water retention and hyponatremia. In hematology, the patient might have anemia, coagulopathy, thrombocytopenia, and hypofibrinogenemia. Coming to investigations, Ask for a complete blood count to rule out infection, anemia, bleeding. Ask for liver function test, RFT, electrolytes, coagulation profile, and then dynamic viscoelastic hemodynamic assays like ROTAM, and then ECG echo to rule out biventricular dysfunction and to estimate pulmonary artery pressure and to rule out any cardiomyopathy. And in some cases, cardiopulmonary exercise testing, it means to uncover systolic dysfunction, which can be masked by hyperdynamic circulation or decreased afterload. And then we can ask for EBG and chest X-ray. Chest X-ray to rule out pleural effusion, and USG abdomen to rule out ascites, liver and spleen enlargement, and then fibroscan to assess the stage of cirrhosis by the texture of the liver. And then preoperative risk assessment tools. The commonly used tools are child Turcot Puig score, which includes bilirubin, albumin, ascites, prothrombin and encephalopathy. It has got three classes based on the ratings. So class A, class B, and class C. In 5 to 6 points. In class A, class B is 7 to 9, and class C is 10 to 15. This CTP score is to predict 1 and 2 year survival rate in CLD patients. And then MEL score, which includes serum albumin, creatinine, and INR. It helps in the priority for liver transplant. It is first introduced for 3-month mortality for TIPS. And MEL score of less than 10 can undergo elective surgery. 10 to 15, we have to proceed surgery with caution. And if the score is greater than 15, the patient should not be operated because the risk of post-op failure will be more. And then coming to anesthetic goals in liver disease, it is to maintain adequate hepatic blood flow, to preserve renal perfusion, and to prevent electrolyte imbalance, and to maintain normoglycemia, to prevent encephalopathy and coagulation failure, to avoid hypoxia, hypercarbia, and hypotension, and to avoid hypothermia, acidemia, and hypercalcemia. Preoperative consideration is to optimize the intravascular volume status. In case of ascites, paracentesis is done to improve oxygenation and prevent aspiration, and to correct electrolyte abnormalities, and then correction of coagulopathy to optimize glycemic status and nutritional status, and to prevent infection, and to watch out for encephalopathy signs. Coming to intra-op consideration, standard ASA monitors, ECG, NIBP, SpO2, ET temperature should be attached. And then for severe patients with severe liver disease and anticipated blood losses, intraarterial BP is advised for continuous BP monitoring, central venous catheter for venous access, and vasopressor administration if required. Fluid shift secondary to drug-induced vasodilatation or drainage of large volume ascites should be anticipated. Hence, volume status need to be constantly evaluated since patient is at risk of AKA and hepatorenal syndrome. Observation of cardiovascular variables, urine output, and blood loss is augmented by cardiac output monitoring. Transesophageal echocardiography is a sensitive cardiac monitor, but not indicated in patients with esophageal varices or coagulopathy. The alternative is PICO, that is pulse index continuous cardiac monitoring. And then based on the surgical procedure and patient factors, plan of anesthesia is decided. Either neuraxial or general anesthesia or moderate anesthesia care can be carried out. In case of neuraxial anesthesia, in neuraxial can avoid the usage of sedatives, opioids, and post-op encephalopathy. There will be a less blood loss and less thromboembolism risk. But we have a risk of systemic hypotension and decreased hepatic blood flow, which is anticipated, and we have to treat it with IV fluids and vasopressors. And then high thoracic neuraxial blockage again may reduce hepatic blood flow and may not be reversed with vasopressors. And neuraxial blockade is usually avoided in patients with coagulopathy. And then general anesthesia, coming to general anesthesia. General anesthesia has the ability to optimize ventilation, but care should be taken on induction of anesthesia. Rapid sequence induction is preferred as patient is prone to aspirate gastric contents. All volatile agents decreases the hepatic blood flow to a degree, among which isoflurane, sevoflurane, desflurane has very little reduction of hepatic blood flow. Halothane is associated with greater risk of hepatotoxicity. And then altered drug metabolism and decreased synthesis of plasma binding protein takes place in liver disease. Pre-medication with benzodiazepine should be avoided because there will be a prolonged depression of consciousness and encephalopathy precipitation might occur. Then propofol in titrated doses can be used for IV injection. Fentanyl also can be used. Atracurium or cisatracurium, owing to the lack of hepatic excretion, is the drug of choice of neuromuscular blocking agents. Dracuronium and rocuronium will prolong the elimination. Succinyl choline metabolism is prolonged due to the decreased pseudocholinesterase in a liver disease patient. And then in ventilation, lung protective ventilation strategy is maintained. That is low tidal volume with a PEEP or intermittent lung volume recruitment, which is advised. In case of hemodynamics, isotonic crystalloid should be used to replace fluids, which is administered via fluid warming devices. To avoid fluid overload or hypovolemia, near zero fluid balance should be maintained by appropriate monitoring. And to maintain normotension and normothermia should be maintained. Noradrenaline is the vasopressor of choice. Vasopressin as a second line treatment in case of hypotension. Emergence may be delayed or complicated by vomiting, aspiration, hypotension, respiratory depression, or acute respiratory failure. So extubation should be done when the patient is fully awake. In case of decompensated liver disease, patient might need post-op ventilation. And then post-operative consideration. Patients with liver disease are at high risk of post-operative morbidity, including hepatic dysfunction, hepatic decompensation, AKI, wound infection, spontaneous bacterial peritonitis, pneumonia. So the patient should be monitored in ICU after the surgery. Close observations of signs of jaundice, ascites, and coagulopathy is mandatory. Venous embolism prophylaxis is advised. Fentanyl and titrated doses is preferred opioid for post-op analgesia. Paracetamol in reduced doses can be administered. NSAIDs should be avoided because of the risk of nephrotoxicity, platelet dysfunction, and GI bleeding. Regional anesthesia in form of local infiltration aid in post-op analgesia. Laxatives is given to reduce the chance of hepatic encephalopathy. And then renal function must be closely monitored. Careful attention is paid to intravenous infusion and serum electrolytes. That's also.
Very good. Most of you should not have any difficulty in answering a question like this because liver disease and anesthesia is both a practical question, viva, as well as your theory. So when you prepare for your practical presentation of a case with liver disease, you know all the points, and what you have to do is just repeat writing them, but try to answer them within the 20 minutes time that you have to answer. Okay? So you have to make it concise and do it. And you correctly started off saying the type of, because if they say liver failure, as you rightly put it, it can be acute or chronic. Okay? But most of the time, acute liver failure patients may not come for any major procedures. If at all, they may come for some endoscopic or interventional procedures, but they may not, unless they undergo a trauma like a fracture or anything, they may not come for an elective procedure. Unlike a chronic liver failure patient coming for a hernia raphe, or a chronic liver failure patient coming with hematemesis because of bleeding varices in the esophagus as a quasi-emergency procedure, or an appendicitis in a chronic liver failure patient. That sort of situation mostly does not happen in acute liver diseases. So you are more worried about saving the patient going in for acute encephalopathic disorder and mortality rather than any need for surgical intervention and the risk involved. So your answer has almost completely included all the answers that is required.